Antiphospholipid syndrome and neuronal linkage. Antiphospholipid syndrome is not just a clotting disorder. It is an autoimmune attack that can disturb brain blood flow and silence neurons. In antiphospholipid syndrome, abnormal antibodies attack phospholipid binding proteins, triggering blood clots, vascular inflammation, microvascular injury. When these clot reaches the brain, neurons may lose oxygen and nutrients, leading to stroke, seizures, migraine, memory loss, cognitive decline, and neuropsychiatric symptoms. Hi, my name is Dr. Vyas, and today we're going to discuss antiphospholipid syndrome. Autoimmune thrombophilia caused by persistent antiphospholipid antibodies. Venous thrombosis, arterial thrombosis, pregnancy morbidity, and organic ischemia can be primary or secondary or associated with SLE. Neurological involvement is common because the brain is highly dependent on continuous blood flow. Classical triad, thrombosis, DVT, pulmonary embolism, stroke, pregnancy morbidity, recurrent miscarriage, fetal loss, and preeclampsia. Persistent antibodies, LA, ACL, anti-B2, GPI, these are the important antibodies that are involved in these incidents. Lupus anticoagulant, anti-odulipin, antibody ACL, and anti-beta-2 glycoprotein 1. These are the major antibodies. Bind phospholipid binding proteins on endothelium, platelets, monocytes, and trophoblast, results prothrombic and immune activation and vascular injury. Thrombotic pathogenesis, that is very important. Antiphospholipid antibodies, beta-2 GPI binding on cells, endothelial plus platelets activation, tissue factors, thrombin formation, tubular clot plus microthrombi, that is for the microvessels, vessel occlusion and ischemia. Amplifiers, inflammatory cytokines, oxidative endothelial stress, reduce anticoagulant service. That is the clinical endpoint. Microcirculation vessels, especially cerebral vessels, retinal vessels, that might be occluded or that might be blocked by these proteins or antibodies. Why brain is vulnerable, and that is very important. Cerebral vessel clot causes reduced blood flow to the brain, plus that is the brain get deprived of oxygen and glucose and causes neuronal injury or neuronal death. Ischemic neuronal injury cascade, thrombus, ATP depletion, sodium potassium pump failure, glutamate release, and calcium overload causes mitochondrial damage of the neurons, plus loss plus inflammation, or you can say negative oxygen species plus inflammation, that leads to apoptosis or necrosis, and that is the neurological deficit caused by these all factors. The main outcome of this is ischemic stroke, TIA, seizures, cognitive decline, headache, movement disorder. Neurological manifestation: stroke, TIA, acute focal deficit, weakness, aphasia, visual symptoms, seizures, cortical ischemia or microvascular irritation, headache, migraine, vascular inflammation, cognitive dysfunctioning, chorea, movement disorder, basal ganglia may involve in this, and optic or spinal involvement, causing optic neuropathy, and transverse myelitis like syndrome. Diagnosis: venous thrombosis, arterial thrombosis, stroke, TIA, or pregnancy morbidity. Laboratory evidence: lupus, anticoagulant, IgG, IgM, beta 2, GPI, and persistent positivity. Confirmed persistence: repeat antiphospholipid antibody testing after every 3 months or at least for 12 weeks apart. Neuroworkup may include MRI, CT, CTA, MRA, MRV, or venous thrombosis, EEG, seizures, neuropsychological testing for cognition. Treatment: uh, prevent clot recurrence, acute thrombosis, immediate anticoagulant, low molecular weight heparin may be given, but in pregnant women, the low molecular weight heparin may not be given uh, to the pregnant woman. Vitamin K, INR target and utilize specialist, avoid interruption without medical evidence. Risk factors: stop smoking, control BP, diabetes, avoid estrogen. When high risk, treat as early inflammation if persistent. This disease is present or persistent. Neurological APS requires secondary stroke prevention, anticoagulant plan plus vascular risk control, rehabilitation, seizures management if needed. Obstetric APS, that is important. Low dose aspirin plus prophylactic heparin, low molecular weight heparin may often use monitor fetal growth and placental function. Warfarin is generally avoided during pregnancy. Catastrophic APS, a rare emergency condition. Multi-organ failure risk, urgent anticoagulant plus immunomodulatory therapy. Patient education, especially women with the pregnancy, may be educated for this disease. Prognosis: good prognosis, early diagnosis, adherence, anticoagulant therapy, control vascular risk, no recurrent thrombosis. Poor prognosis, triple positivity antibody profile, recurrent events despite therapy, gastrotopic APS coexisting SLE or inflammation. The outcomes of this disease is very important, and few factors are involved uh, in the prognosis: infarct, brain size, brain area involved, reoccurrence prevention, rehabilitation, cognitive support. Prevention of the recurrent clots is strongest strategy for neuronal protection. That is a summary. Antiphospholipid antibodies, beta 2, GPI especially, platelet endothelial activation, thrombin plus factor, fibrin clot, brain vessels occlusion, and neuronal ischemia. That is the neuronal cascade that leads to the death of the neurons in the brain. The clinical outcomes of neuronal death is the stroke, TIA, seizures, cognitive dysfunction in headache, chorea, optic, or spinal ischemic features. Important points: APS is an autoimmune prothrombic disorder. Neuronal linkage occur mainly through cerebral thrombosis, cerebral flow, microvascular ischemia, and immune inflammatory vascular injury. Early recognition of stroke, TIA, seizures, and cognitive is very important. Long-term clot prevention protects the brain and improves prognosis. Thanks and regards. Please like and subscribe this channel for further discussion on rare diseases. Thanks.